Anyway, we'll get through this. Like I said, Mom does the majority of the work, the majority of the time. The only time that somebody else would ever get in contact with, as far as delivering, is to essentially catch. That way they don't have what's called a precipitous delivery. Precipitous would mean fast. We've got a couple of videos, and I'll show you a precipitous delivery that they need to control. It could be life-threatening if the baby comes out too fast, and you just want to guide the baby out. So the person delivering the baby doesn't have necessarily a lot of work. They just sort of guide the baby out, and like I say, the upwards of 97, 98% of the time, you only have problems just a short amount of time in deliver baby. Everything's fine. We'll talk about some of the problems as we go through. We want to look at the anatomy right quick, because this is going to tell you some things that they're going to do. And we're going to focus in hospital delivery, not out of hospital delivery. It would be a mistake or an emergent situation if you guys ever came in contact with the delivery at the hospital we go to, because they don't have OB services. There has been deliveries there. Mom starts going to the hospital, they can't make it, they pull in. And the student saw a live delivery a few years ago, and they had one just the other day that they should have delivered at the hospital. They put it in the back of the ambulance. The doctor went with the ambulance to the other hospital, and they delivered it en route. The mom was already crowning, which was imminent delivery. And for me, as a paramedic, I wouldn't have taken it. I refused to call. They're about to deliver the baby. The mom's crowning. We're going to deliver the baby here, and we'll take it later. Not in the back of the truck. But we'll look at a couple of things. You were fortunate enough to go to the organ thing, and you could see the uterus, right? Uterus, what houses the baby. It's real small, but man, it stretches out, doesn't it? The head down is the natural position of the baby. The baby will, as it gets closer to delivery, will naturally turn, okay, to go head down if everything is going okay. So the uterus is sort of the sac. It's sort of what it's attached to. The placenta attaches up top, and that's where the baby gets all of its nutrients, blood supply, everything goes through the placenta. And the baby's surrounded in amniotic fluid, or this real thick sort of fluid that one acts as a shock absorber for the baby. The baby moves, so the baby's in there. Cervix, birth canal. Now when you look down, what they will do in the hospital, moms, this is what you have to look forward to. When you go to the hospital and have your baby, one thing they're going to do is do a quick cath. They don't void the bladder. They don't empty the bladder out. It's more than you just going to the restroom. They're going to completely empty the bladder out. That way you don't urinate on the doctor. Okay? And most of the time they're going to do a... hold on a moment. They don't empty the rectum out as well. They don't enema. They don't give you an enema. That way, there's nothing in there to expel as the baby starts to push, because you can see they're going to push directly on both. And you can see now why that in late term that mom always has to use the bathroom. You got a big bowling ball sitting on top of your bladder. You know, if you were to go and you just push down your bladder all the time, you'd have to go all the time as well. All right? But this is the natural position of the baby. We'll sort of go into a couple of different things that takes place with the placenta, problems, and a couple other things. But primarily, we're just going to focus on natural, normal child delivery. There's 3 stages of labor that you need to know. The first stage begins at full dilation of the cervix to delivery. dilation of the cervix. So the first stage begins at the dilation of the cervix up to delivery. All right. The second stage begins at delivery. Okay. Of the baby. I like the way it puts expulsion, but with delivery of the baby. And then the third stage is the delivery of the placenta. So to keep it simple, first stage is when the cervix is dilated. All right. Second stage is when the delivery is. Third stage is the delivery of the placenta. In all three of these, the placenta is delivered just the same as the baby, except that it doesn't hurt as much because it's very pliable. Before we get into some of the delivery process, we'll look at these pre-delivery emergencies because these are some of them are quite life-threatening. First, we look at preeclampsia. Preeclampsia is where the mom starts getting the headaches and dizziness, the swelling, get the cankles that really start having a lot of fluid retention. But primarily hypertension. So when you look at someone that's preeclamptic, they're all swollen up, they're all puffed up, but they're hypertensive. Now remember, everything that happens to the mom sort of goes along with the baby, right? So you get this preeclamptic state where the patient's hypertensive. Eclampsia, which is life-threatening. I had a friend of mine, a coworker, die from eclampsia, where you start having seizures. So what happens normally is that the patient, you go in, someone that goes and sees the doctor on a regular basis, they check them, they check their blood pressure, their weight, they make sure they're doing okay. If that pressure starts to rise up, they'll put them on bed rest before they get preeclamptic. And a lot of times the moms, just like this one, a particular lady, she couldn't go on bed rest. She had to work, right? Everybody likes to eat. So she had to work. She was an EMS dispatcher. And not only did she have to work, but she had a high-stress job. So she got preeclamptic, and the doctor said, hey, you got to go on bed rest. Ignored the doctor, didn't do it, and then one night at work, she got eclamptic, or she started seizing. Fortunately for the baby, not for her, because she seized, and from that seizure she had a stroke, but the baby survived. And they left her in the ICU till they could deliver the baby. But she got eclamptic, or she started seizing. So both of these are really true medical emergency. Eclampsia is life-threatening. This supine hypotensive syndrome is where the mom will be laying on the back. They're laying supine, and the baby lays up against the vena cava and causes the blood pressure to drop. So when you have someone in the late term, all right, in the late trimesters, everybody understands trimesters, right? 3 months. So it's broken down, the pregnancy's broken down into 3 trimesters. So probably late when the baby's the biggest, if you have someone like that, they need to lay on their side to keep this supine hypotensive syndrome from taking place. All right? So keep those in mind as we go through this. They're just pre-delivery type emergencies. And then, like we talked about, you get quite a bit of bleeding. The normal bleeding is from about 500 cc's. What happens here, early in pregnancy, you have other problems where you get hemorrhage. This expression, spontaneous abortion, if you want to put the lay term for that, that's a miscarriage. There's several different types of abortions. We typically only think about the elective abortion, right? But a spontaneous abortion is considered what's called a miscarriage. Then you have an ectopic pregnancy. Ectopic means outside. And typically, all of the well, except the males, all of you should know what an ectopic pregnancy is. Ectopic is where it's outside, and instead of the egg lodging in the uterus where it's supposed to be, it gets hung up or lodges or attaches itself to a fallopian tube. Well, as this reproduction very quickly takes place, you will get severe abdominal pain sort of along the lines of the fallopian tubes. So if this was a female poster, you would get pain right across here, sort of right at the belly button. This very sharp, intense pain. And if you would think it was a spontaneous, an ectopic pregnancy, if that was to rupture, then just like a ruptured appendix, all that toxin would go out into the peritoneal or the abdominal cavity, and it could be life-threatening. So anytime that you have severe, very sharp, pinpoint abdominal pain, lower abdominal pain, sort of across where the belly button is, maybe a little bit lower, think of ectopic pregnancy if that patient is in childbearing years. All right, so that's from about 12 to 50. All right. I've delivered I think she was 12 or 13. All right. So you get these pregnancies very young, but you have to think of that, and this is just my point of view, that the female is pregnant until ruled out. I mean, if it's someone older and they said, hey, I've had a hysterectomy, blah, 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 I said, okay, I'll take that one. But anybody younger within childbearing years, for me, it's probably 12 to 40-ish. All right? They're pregnant until ruled out. But they, one, is that you don't want to do x-rays. I mean, there's a lot of things that you wouldn't want to do, or you'd have to be very careful. And a lot of times, especially in the emergent situation, the patient's going to lie to you. You know, if I came out to your house and you were having abdominal pain, and I would say, is there any possibility of you being pregnant?
And your mama's sitting right there.
Yeah, your dad's right there. What are you going to say? No. Not at all. Okay, let's say you were married, okay, and your husband was right there, and I said, is there any possibility of you being pregnant?
Why would you say put someone married?
Well, I don't know, maybe extramarital affairs take place. But so, I never asked that question in the presence of a family member. I always wait, you know, because you're sitting there going, that's because the patient's gonna lie to you. So I wait till we're alone and say, hey, your information's confidential with me, patient confidentiality, right? To a point. Minor's not really, but I'm not going to tell your parents what they don't need to know. Is there any possibility of being pregnant? Because I need to know. So you got to be careful of the way that you ask, but keep note of that, because a lot of the doctors will miss that. They shine it off as appendix, gas, some other pain. But if I was a female and I was having that type of pain, I would rule that out pretty quick because of the threatening manner of it. All right, so that's a few people I've ran into. They thought it was appendicitis and they almost died, or they said, oh, you're just having some abdominal cramping, and the person almost died because the doctor missed it. So that ectopic pregnancy is very important to make sure that you keep on track. And this is what we talked about as well. Okay, some problems with the placenta. You have couple different problems that take place. You have the placenta abrupto, which just sounds bad, right? Abrupto sounds worse than placenta previa. And what happens in placenta abrupto, like it says, it's a premature separation of the placenta up top. But there's a classic sign of placenta abrupto. It is bright red, very painful vaginal bleeding. So bright red bleeding, very painful in abrupto. In placenta previa, the uterus detaches and sort of moves around and keeps the baby. I mean, you can't deliver now. You have to do something else, a C-section or something. And but its classic sign is painless, bright red vaginal bleeding. So painful, painless. So those are like the two classic signs of that. Anytime that the mom, when they are with a child and they have any sort of vaginal bleed, they're going to go to the hospital. That sort of freaks them out. Or they get hit in the stomach. And rightly so. They want to get that checked out. All right, so you should get that checked out. So those are the two problems. They're rare. They're not that common. So they are very rare. So let's look at this, because there is, some size up, some other type of questions, other type of assessment questions, that you want. Obviously, BSI, it's going to be, if you're going to deliver the baby, there's going to be a lot of blood. Make sure that you can remain calm. Trying to keep the mom calm and the family members calm. Usually they're a lot calmer in the hospital situation, but still, they can get worked up pretty easily. So we want to make sure that they remain calm. It's not that difficult, really, to deliver the babies. Now, when you start your assessment, let's say they come in, say you have a clinic, and they come into your clinic, and they say, I think I'm about to have my baby. They come into the hospital. They're in active labor. All right? So is there a medical problem? Is there a trauma problem? If they're in active labor, always do the ABCs, the sample assessment, good first general impression. All right? Then you start in on the assessment. And if you wanted to figure if mom's in active labor, what's one question right away that you would ask?
Are you in any pain?
Huh?
Contraction?
If your water broke, you lost your mucus plug, just like a little plug that comes out, it's a bloody, sort of yucky looking little mess, but the mucus plug comes out and water breaks. Amniotic fluid ruptures. So they say, did you feel like a gushing of fluid come out? Like you urinated on yourself? Oh yeah, I did that in Walmart. Then you're probably going into labor. Now the thing is, if it's the first baby, very typical long labor. I mean, if first baby, water breaks, I've had people clean their house, call their things, make other preparations, call mom, call the husband in, all this stuff. My wife was in labor over 24 hours. So you got a long time. Third baby, I almost missed it because I went down and got some eggs. But as I just got off work, I was hungry. But as the number of pregnancies add up, then the labor gets shorter and shorter. All right. So amniotic fluid, are you due? That's an important part. Are you due, or is this something premature? That's going to be a problem. All right? How many babies do you have in there? Do you have one? Have you seen your gynecologist on a regular basis? Have you been taking good prenatal care? All these are going to give you indications on how well this delivery is going to go. So if they pop in your clinic on the way to the hospital and say they can't make it, so you start asking these questions, and you think you're going to evaluate whether this is going to be a normal delivery for you, or is there going to be a problem. If they say, no, I don't have any prenatal care, I live on the streets, I smoke crack every day, then you're going to have problems. Okay? But if the mom comes in and says, yeah, I got tied up, I waited too long to come to the hospital, I don't think we can make it. So we stopped here. Alright, so you've been going to the doctor, good prenatal care, good sonograms. You know, once the baby gets closer and closer, the doctor's going to do sonograms, make sure that they're in the right position, make sure that they're fully term, measure, alright? So, if that's the case, then it's just going to be a normal delivery. Otherwise, you're going, oh, really? Crackhead, right? It's going to be a problem. Because the baby's going to be probably diminished as well. So start asking those pregnancy type questions as long as the assessments. And now it's your moment of decision. Is this an imminent delivery? So we're going to say, yes, this is going to be an imminent delivery. So you're going to get the mom into the exam room, you know, call the doctor in, or maybe you might be the doctor. Go ahead and start the exam. Try to figure out and get as many of the assessment questions out of the way. But let me tell you, the baby won't wait for your assessment. So you just need to assess whether or not you're going to deliver that baby right away, or do you have some time to deliver the baby. And most of the time you have a lot of time. So here, the doctor, let's say you're the doc, or maybe the nurse there, either one, and you're going to do a physical exam. You're going to check to see if the mom is crowning. If the mom is crowning, then you need to get everything ready to deliver. You're going to deliver very soon. The baby that they delivered a couple of years ago in the hospital, we were sitting in the EMS room, and we saw the nurse push this chair with this lady on it by the door. And they were at a trot. Then we saw this other nurse go in there and at a trot, and thought, well, something's up. So we went in there, and they had a lady in room 3 laid out on the table, and went, oh, delivery. And they turned around and go, yeah, they're crowning. I'm like, oh, they're going to deliver shortly. So I got a bunch of students in there and gathered them up, and we stood from me to you, and they got to watch this delivery. Yeah. The doctor did something a little weird, but he was not from the United States, but and he just made this weird cut that you don't see any people in the United States doing, I think. But it worked out okay.
It was a natural birth?
Yeah. So anyway, so let's make this decision time. Let's say in our scenario that we're going to deliver this baby. So we make sure, like say, due date, prenatal care, how many babies, have you been drinking a lot of alcohol, do you do drugs, has your water broken? We'll get into MEC staining in a little bit, but when you do the physical exam, all right, and there's green fluid coming out, what that means is that the baby has experienced some distress in the birth canal, and it's essentially pooed in the birth canal. So you're going to have to do some very aggressive suctioning there, but that would be what's called MEC stain. And it could get in their lungs, so that's the problem there. So we focus on the abdominal. Take any other chief complaints. Pay especially attention to tachycardia. Tachycardia, sustained tachycardia, is a sign of bleeding or sign of shock. First sign of shock. Hypotension. Man, that's because if the mom's hypotensive, the baby's going to be hypotensive. And we don't want that. Okay? Or hypertension. We want everything to be normal, which is, like I said, the majority of the time, all the births are normal. So we did the focused physical exam. We looked to see if the mom's crowning. And then we start treating the mom. We get ready for the delivery. We want to make sure that we get mom in the proper birthing position. All right. We gather up the materials that we don't need, mainly some absorbent towels, something to keep the baby warm. Even post-delivery care is very important. The baby's coming out of a 98-degree environment into a room that's probably in the 70s. So they're going to get very, very cold quickly. It's like you going from here, you're inside, and it's 70 degrees inside. Then you go outside and it's 50 degrees. But you go outside without any clothes on. Okay, so you're going to get cold quick. The baby, you don't want to get cold. That will cause the baby some distress. It's already sort of in a little distress. Delivery is very hard on these guys. All right? So if you can sort of consider, this is going to take place, and so that you try to start the delivery. So BSI, prepare an OB kit. We'll look at that, essentially what an OB kit here is in just a minute, some of the pieces and parts that you'll need. But this is what I'm trying to get to when you're talking about getting mom sort of in a birthing position, hips up, legs up, and, have some modesty, some privacy. If this is number 3, you still want modesty and some privacy, right? First time moms are real sensitive to this. So you've got to be sort of aware of that. But this is what we're saying about crowning. And this is an advanced crowning. I mean, you can sort of say the head starting to protrude through. If you did your initial exam and you see this and you go, oh wow, baby. I mean, you're going to deliver fairly quickly, but the thing is, you have to control that delivery. You just don't want it to pop out at you and say hello. I mean, you got to slow that delivery down. Mainly because every time I give this lecture, I want to look this name up. But this tissue right here, that's in between here, is very vascular. And that is the problem with precipitous delivery. If that tears, that is life-threatening. They will hemorrhage. They will bleed to death by a tear. So you have to control that so that tissue there doesn't tear. You're seeing the video, they do what's called a episiotomy, and the doctor will cut that. That's okay to cut it because he's controlling it. It's not ripping, it's not tearing. But this takes place, and you have to do that if the baby's big and the mom is small, then there's going to be a problem. Okay? Let's say you marry a basketball player, okay? And they're measuring your baby, and your baby measures out at 9 pounds. You are having a C-section. You are, because that's going to cause major problems. All right? There's some moms that have, they're built better for birthing babies. Others are not. And the baby goes through a tremendous amount of stress as they sort of try to fit through that small birth canal. So a lot of times they will elect to do a C-section over trying to deliver that. But if we have a tear, that's going to be a problem. So we prepare for delivery. We sort of look there and say, okay, mom's crowning. If there's just a sort of a bulge there, the video is worth 1,000 words. So when we see the video, I'll pause it and say, that's crowning. Okay? So so now, let me hit the lights because...
That's good.
So, baby's coming out, head emerges, okay? The baby's going to come out face down, alright? Here's a very important part where you should pause. Now, you're controlling this. Hopefully, mom has had Lamaze, and they're breathing through this, and they're pushing. They're having a contraction, and you push with the contraction. The head emerges, okay? This bulb suction syringe, you want to suction right here, okay? Because if you wait till here, like it's in the video, the baby just took a breath. Soon as that thorax clears that birth canal, that baby's responses don't go, right? And if they still have a lot of amniotic fluid and other fluids in there, they could possibly aspirate that, which is very dangerous for the baby. So once the head emerges, just like the picture is, suction, all right, until you get a clear airway. Then as the baby comes out, the second step, you can sort of see it turn. So the baby will sort of naturally turn, and you just sort of, as the baby turns, you lift that shoulder up to get one shoulder out. And then once this takes place, once the head really comes out, you just sort of lift up and that shoulder comes out. Then you have baby. All right? So, and they're very slippery. So be careful not to drop them. And then you get in after this to clamp and cut the cord. Like I said, it's almost just a natural thing that takes place. Okay? And the majority of the time, there's no problems with it. You just sort of assist the delivery to keep the baby from coming out too fast. Remember that here you pause, okay, and then suction. And this just sort of, once you get here, you just tell mom to push on the next contraction. Mom has the next contraction. The baby's going to turn. You lift up on the shoulder. Then you say push. You know, in TV they say push, push, push right now. And they want to get that last push because the shoulders are coming out. And then boom, you have baby clamping. Then you have things after the birth. You know, clamp and cut the cord. And you still have the delivery of the placenta. There. Some complications. Unruptured amniotic sac. It's no problem. The nurse or the OB, the doctor will pull on the sac and cut it. If the kid starts coming out with the amniotic sac still attached, they'll just pull the amniotic sac away and cut it, and then it will rupture. Not a problem at all. Umbilical cord around the neck, I think actually the video shows this. It's not a problem if you notice the cord. Head comes out and say, oh, there's a cord there. Don't push. So you essentially just take two fingers, get it up underneath the cord, and just pull it over the head. If it doesn't come over the head just easily, then you do have a problem. The cord is tangled up some way. So there is a bigger problem there. We won't go into that because that is a big problem. Okay? But most of the time the cord is pretty long enough, really long enough, you just sort of pull it over the head. If it won't come up over the head, you'll have to clamp and cut it then. But you want to make sure you clamp and cut opposite ends. In the umbilical cord itself, there's two arteries and one vein. I always get that backwards, but I think it's two arteries and one vein. So if you don't clamp the cord, then the baby can easily bleed to death from an unclamped cord. Once the baby's delivered, make sure that they get warm. They're going to be wet. We've already talked about someone being wet. They lose body temperature 25 times faster, right? So does baby. The body temperature will start to drop. So you got to get them warm, get the blankets, suction them. In the hospital, they should have a table where they stick them underneath a heat lamp to get them warm, to dry them off. You still have mom, right? There's still a process there. You don't deliver the placenta as well. The placenta will deliver 25, 30 minutes after the baby, but they still don't have contractions, okay? And you deliver the placenta. Now, the baby is going to be naturally blue, cyanotic on the extremities. Centrally, head and chest, they should be sort of pink, but naturally cyanotic. And they will pinken up as they start to cry. You want them to cry to work those lungs, and you want them to wipe them off. It's called tactile stimulation. You dry them off and you wipe them off to stimulate them to cry, so you get the heart rate up and get them working and breathing. A crying baby at birth is what you want. You want them to work a little bit to do that. And that's all very natural for them to do. A cyanotic baby is very bad, and I doubt in this class if we'll get into resuscitation of the neonate, but I think enough it's just the delivery aspect of it, because you get so few of those. One thing that you will have to do with the mom is after the baby's delivered and dried off and taken care of, the mom's going to still be some bleeding. You want to control postpartum bleeding. So what you do is, it's called massage the fundus. And the fundus is sort of the top part. You'll feel it. It's where the uterus is still enlarged. You'll be able to see it and feel it in the abdomen. And you massage that. And I don't mean massage it like, oh, this feels so good. I think they do it on the video. You'll see them take their fist and they sort of dig into the abdomen like that and push into the abdomen. What this does is it causes the uterus to contract, and it will control that postpartum bleeding. Now, if they're bleeding excessively, then you would really massage the fundus to try to get it to contract to control that bleeding. All right? And those are sort of steps that you'd go through. When you deliver the baby, they get what's called an APGAR score. And you do an APGAR at 1 and 5 minutes. I won't make you memorize anything really about the APGAR. I just want you to know the definition. So the APGAR is a scoring at 1 and 5 minutes to see how well the baby's doing. And they grade it on appearance, pulse, grimace, activity, and respirations. So are they mainly pink? Do they have cyanosis at in the extremities? If they have central cyanosis, then they get less points. All right. Pulse, is that pulse above 100? You want that baby's pulse to be above 100. If that pulse is below 60, you'd start compressions. Grimace, their face all, when you're doing the tactile stimulation, do they grimace like you're sort of a little uncomfortable? Are they moving their arms and legs? And are they breathing? Breathing more than about 30 times a minute. So are they breathing the normal respiration? But for this class, I just want you to be familiar. So if someone says, oh, the APGAR score, you know that's a score that they grade the baby on. Pre-hospital delivery, you definitely want to do this 1 in 5 minutes, because this is their baseline. This is how they're going to assess the baby. You have an OB nurse or OB doctor get very angry at me as far as pre-hospital if I don't do an APGAR. They want that. They want that score. But for you guys, I just want you to sort of know what it is by definition. All right, any questions there? All right, before we go to the video and watch a natural, let's talk about some problems with where there is a problem. All right, where the baby's breech, where their head up. You won't know this except when you start delivering them. You see you do a physical exam, like to see if they're crowning. Instead of seeing the top of their head, you see their butt. And Now a breech baby is still, you can still deliver that baby without C-section, it's okay. The baby will just have to, you just have to deliver them backwards. So we really won't get too much into the delivery. There's a little bit more here about this, but essentially, after you on a breech baby, they're coming out feet first, both feet first. You'd have to sort of, with your gloved hand, you'd have to go up in the birth canal and make sure that the airway is not compromised. So you have to find the head and lift up on the head so that when the thorax clears, that the baby's face is not face down and they're suffocating. So you go and you lift their head up while the head's being delivered. Now the feet will come and the thorax will come quite quick. It's the head that takes a little bit of time. So you're going to get tied up with that. Plus, they're already trying to breathe. So suctioning is going to be a problem there. So not completely uncommon. Any of you guys know if you were a breech baby? No?
My parents don't talk about that.
Yeah, your parents don't. Hadn't gotten that conversation?
No.
Okay.
No. They find something else to talk about. I know what to talk about.
The other presentations that you'll look at that are very rare is a limb presentation. If go and say you have the same patient, they're in your clinic, they come in the emergency department, you do your physical exam, you look down, and all of a sudden, boom, you see a foot. There's nothing you can do. The baby, you cannot deliver a baby with a foot or a hand presentation or a limb presentation. It requires an immediate C-section. All right? So you can't deliver there. All you can do is support mom's ABCs, vital signs, and get them to surgery. There's an impossibility of delivering that baby outside the OR. A prolapse cord is sort of the same way. You can still deliver this baby if you have to that way, but you have to, like I said, there's a couple arteries here. So one, you want to make sure here that, and most of the time it won't be delivered. It has to be really delivered by C-section. But you get a prolapse cord, and what you want to do is, again, insert your fingers in the birth canal. See if you can find a pulse on the cord. If you can find a pulse on the cord, then you're really okay. If you're not, if you can't find the pulse, that usually means that the baby's head is leaning up against the cord, and it's like a tourniquet. It's cutting it off. It's not getting blood supply. So you have to lift the baby head off the cord. Pre-hospital wise, you're going into surgery with them. You're not letting that baby go, moving that head. You're just walk straight into surgery with them, and then do a C-section here. But again, these are, when they say rare, these are really rare. Not only have I not seen that, but all the people I know in 20 years of EMS have never seen a limb or a prolapse cord or presentation. A breech, yes, but these never seen. I'm sure they happen, but they're very, very rare. Remember, if you start getting more than 500 cc's of blood, you need to sort of massage that fundus. Make sure that they don't. They try to start slowing their bleeding down. All right.